Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Randomized Comparison of Surveillance Intervals in Familial Colorectal Cancer by Simone D. Hennink et al. My name is Matthew Yergelin, and I'm a physician at the Dana-Farber Cancer Institute and an instructor of medicine at Harvard Medical School, both in Boston, Massachusetts, USA. My oncologic specialty is gastrointestinal medical oncology and hereditary gastrointestinal cancer syndromes. Adenomatous polyps are the precursor lesions for the large majority of colorectal cancers, and it is thought that periodic endoscopic removal of adenomas will reduce one's future risk of developing colorectal cancer. Indeed, large observational studies have shown that colonoscopy with polypectomy is an effective intervention for reducing both colorectal cancer incidence and colorectal cancer-associated mortality in the general population. Current guidelines by organizations including the United States Preventive Services Task Force, the National Comprehensive Cancer Network, the American College of Gastroenterology, and others endorse the use of colonoscopic screening in average-risk individuals beginning at age 50 and at 10-year intervals thereafter for individuals with a normal colonoscopy. A family history of colorectal cancer is a common and well-established risk factor for the development of colorectal cancer. A small fraction of individuals with a family history of colorectal cancer will have a high penetrance hereditary syndrome such as Lynch syndrome or familial adenomatous polyposis, but the majority of such family histories are not attributable to these rare Mendelian disorders. Such individuals are sometimes classified as having quote-unquote familial colorectal cancer and are thought to have risks of colorectal cancer that are anywhere from 2 to 6-fold higher than the general population. As such, individuals with family histories of colorectal cancer are typically recommended to undergo colonoscopies more frequently than the general population, although there are minimal data and no available randomized clinical trials to suggest a specific interval for colonoscopic screening in such individuals. In the study that accompanies this podcast, Hennink and colleagues report their findings from the Familial Colorectal Cancer Surveillance, or FACTS, study, which was a multi-center randomized controlled clinical trial performed in the Netherlands by investigators from the Netherlands Foundation for the Detection of Hereditary Tumors. The aim of this study was to determine the optimal interval for colonoscopic surveillance in individuals considered to have familial colorectal cancer. Participants aged 45 to 65 were recruited to the study from 2002 to 2007. For the purposes of this study, the investigators considered participants to have familial colorectal cancer if they had a single first-degree relative with colorectal cancer diagnosed before the age of 50, or if they had 2 first-degree relatives diagnosed with colorectal cancer at any ages. Participants were excluded if they had additional relatives with colorectal cancer, a personal history of inflammatory bowel disease, prior colorectal surgery, or a first-degree relative with colorectal cancer demonstrating high-level microsatellite instability or other evidence suggestive of Lynch syndrome, such as a history of endometrial cancer. After a baseline colonoscopy, participants were randomized to have follow-up at either 3 years or 6 years. Those who were randomized to the 3-year follow-up group then went on to have a second colonoscopy after another 3 years, thus 6 years from initial randomization. Participants whose baseline colonoscopies demonstrated 3 or more adenomas were excluded from the study. The study's primary outcome was detection of an advanced adenomatous polyp, which was defined as being an adenoma of greater than or equal to 1 centimeter in size and or an adenoma with high-grade dysplasia or with villous or tubulovillous architecture. The study's secondary outcome was the detection of adenomas of any sort. By intention-to-treat analysis, participants randomized to 6-year follow-up had a higher rate of advanced adenoma detection at follow-up colonoscopy compared to those randomized to 3-year follow-up, although this difference was not statistically significant, with the odds ratio of 2.0 having a 95% confidence interval from 0.89 to 4.7. Of note, a single participant in the 3-year follow-up group had a T3N0 splenic flexure colon cancer detected at 3-year follow-up, and this was counted as an advanced adenoma for the purposes of this study. No participants in the 6-year follow-up cohort had an incident colorectal cancer detected. Detection of any sort of adenomas, the secondary outcome measure, was significantly more likely in participants randomized to 6-year follow-up at 26% compared with those randomized to 3-year follow-up at 13%, giving an odds ratio of 2.4 with 95% confidence intervals of 1.5 to 3.9. The authors noted that their study cohorts were imbalanced, with 5.6% of participants randomized to 3-year follow-up having had an advanced adenoma at baseline, compared to only 1.9% of participants randomized to 6-year follow-up. When the authors adjusted their analysis for this imbalance, they found that the increased detection of advanced adenomas in the 6-year follow-up group was statistically significant compared to the 3-year follow-up group, with an adjusted odds ratio of 2.44 and 95% confidence intervals of 1.03 to 5.78. Per the study protocol, participants randomized to 3-year follow-up underwent a second colonoscopy in another 3 years, and thus had 2 colonoscopies over a 6-year span, whereas the comparison group had a single colonoscopy over the same 6-year span. In their intention-to-treat analysis, participants who had 2 colonoscopies over the 6-year span had lower rates of advanced adenomas detected at 6 years, 3.4% versus 6.9%, compared to those who had undergone 1 colonoscopy over the 6 years, although this was not statistically significant. Again, adjustment for the differing rates of advanced adenomas at baseline examination did result in this difference being statistically significant, with an adjusted odds ratio of 2.61 and 95% confidence intervals of 1.06 to 6.45. The investigators analyzed whether participant sex, age, strength of family history, and baseline colonoscopic findings predicted for the detection of advanced adenomas at first follow-up colonoscopy. Of these potential risk factors, they found that only the presence of advanced adenomas at baseline significantly predicted for the detection of advanced adenomas at first colonoscopic follow-up, with an odds ratio of 5.21 and 95% confidence intervals of 1.61 to 16.87. This study provides important insights into the preventive management of individuals with a family history of colorectal cancer. Participants in this study, all of whom had a family history of colorectal cancer, were able to be safely screened at a 6-year colonoscopy interval compared to the more aggressive 3-year interval. Although the participants randomized to 6-year follow-up did have higher rates of adenomas overall compared to those undergoing 3-year follow-up, there was no statistically significant difference in the rates of advanced adenomas and, importantly, no incident colorectal cancers in those having 6-year follow-up. The authors did find that participants with advanced adenomas at baseline colonoscopy were significantly more likely to have advanced adenomas at their next follow-up. Furthermore, the study cohort's imbalance with respect to the presence of advanced adenomas at baseline prompted subsequent statistical adjustment, with the adjusted odds ratios demonstrating a significantly higher rate of advanced adenomas at follow-up in the individuals randomized to every 6-year colonoscopies versus those having colonoscopies every 3 years. As such, the authors concluded that an every 3-year interval might be appropriate for individuals with advanced adenomas. The study's strengths include the use of a randomized controlled trial, as well as the degree of participant compliance, with over 84% of participants completing their colonoscopies as assigned per study protocol. There were also very minimal missing data in this study due to the use of medical record and pathology verification of reported family histories, as well as the use of centralized histologic review of the adenomas removed from study participants. Ultimately, the goal of colonoscopic screening and polypectomy is to reduce colorectal cancer-associated morbidity and mortality. As noted by the investigators, this study was neither designed nor powered to evaluate differences in colorectal cancer incidence or colorectal cancer-associated mortality. Instead, this study used advanced adenoma detection as a primary outcome, which is biologically sensible, but is nonetheless still a surrogate for colorectal cancer-associated morbidity and mortality. Furthermore, this study does not address the question of the optimal timing for initiating colonoscopic screening in individuals with a family history of colorectal cancer. Guidelines put forth by both the American College of Gastroenterology and the National Comprehensive Cancer Network recommend that individuals begin colonoscopic screening at age 40 or 10 years younger than the earliest colorectal cancer diagnosis in the family if they have a first-degree relative with colorectal cancer diagnosed before age 60, or at least 2 first-degree relatives with colorectal cancer at any age. Such age-specific recommendations, however, are not evidence-based. This study did not describe data on serrated polyps, which are thought to be the precursor lesion for a minority of all colorectal cancers, but may account for a disproportionate fraction of right-sided colorectal neoplasia. Histologically, serrated polyps can be misidentified as hyperplastic polyps, and the appropriate colonoscopic screening interval for individuals with serrated polyps remains unknown. It is also worth emphasizing that this study's findings are not generalizable to all individuals with a family history of colorectal cancer, since those with particularly strong family histories were excluded, as were those with inflammatory bowel disease, or with 3 or more adenomas found at baseline colonoscopy. For such high-risk individuals, more aggressive colonoscopic surveillance may be warranted. Furthermore, participants with suspected Lynch syndrome were excluded, and there are robust long-term observational data suggesting that colonoscopic screening every 1 to 3 years, beginning in young adulthood, is associated with reduced colorectal cancer incidence and mortality in individuals with Lynch syndrome. For the much more common scenario of an individual with a family history of colorectal cancer in the absence of a particular genetic syndrome, however, the findings by Hennink and colleagues in their FACTS study provide important and novel data on the use of colonoscopic screening. Based on the data from this randomized clinical trial, individuals who have a family history of colorectal cancer in 1 or 2 first-degree relatives can likely be safely managed with colonoscopic screening every 6 years, provided that their baseline colonoscopy finds no adenomas with advanced pathologic features and no more than 2 adenomas total. Future larger studies will be needed, however, to confirm whether or not this 6-year interval is effective at minimizing colorectal cancer-associated mortality in such individuals. This concludes the JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.